So hi everybody, I apologize that I don't get to be with you in person. So I am out of town at a conference. So I'm going to be here virtually via this lovely videotape. So I'm dressed brightly. Apparently you don't see my whole body, but if you can see my lower half, you can see my bright pants. And I wore polka dots to try to keep you awake, because I know you're seeing me late in the day, so I will do my best to be energetic and hopefully it will come through on the video. So what we're going to be talking about today is delirium, psychosis, and Suboxone. Oh my! The truth is there's also dementia in there, but it didn't fit with my title, so we're going to talk a little bit about dementia as well. So we're going to talk about key features of delirium, and then how is it that you can think about a framework to discern delirium versus dementia versus someone who's acutely psychotic, because there's certain things that can look similar between those things, but teasing them out is important because the treatments are going to be very different depending on what you sort out is going on with the patient. Then we're going to talk about the opiate epidemic, and then we're going to talk about management of opiate use disorders. So we talked a little bit last year in Psych Skills about the opiate epidemic. I introduced Suboxone very briefly. We're going to spend a little bit more time talking about that today. So those are the things we're going to be covering, and by covering these things, I'm hoping you'll be able to do the following. You'll be able to apply key concepts of a framework to be able to differentiate between delirium, psychosis, and dementia, have an understanding of the impact of the opiate epidemic. So, and the last thing I'm hoping you'll be able to do is understand the pros and cons of different opiate use disorder treatments. So why is it we would pick methadone versus why would we do Suboxone for a patient versus just putting them through detox and not putting them on an opiate replacement, for example. So let's start with the case. You know I'm a cat lady, so whenever I can, I have my gratuitous cat picture. So there it is for the whole session. This is the one you're going to get. So we have Mr. Mystery Man. We have a 55-year-old gentleman. He carries a diagnosis of schizophrenia, and he was found down. He had a cast on his left lower extremity, and he also had an abrasion on his head. And when it was brought in, it was found that he had a Utox. It was positive for codeine. So this is all the information that I'm going to let you have for now, because I don't want to get too much into the weeds. So this is very general, I understand. So for those of you who are science fiction fans, you probably know what this is. It is a TARDIS, right? So it's a time travel machine. So we have gone 2 days later in our TARDIS, and we are now on the unit, and Mr. M has become agitated. So when the MHS goes to check his vital signs, he appears distracted, possibly disoriented, and the MHS notices that his heart rate is higher than his baseline, which has been around 75, and it's now 115. So Mr. Mystery Man looks very different now than he did 2 days when he was brought in, 2 days ago when he was brought into the hospital. So, what is going on? How would you sort out what's going on for him? So what I'd like you to do is I want you to pair share, chat with a neighbor or two, depending on how many people you want in your group. I want you to think about two things. Cast a broad net. What could possibly be going on? I've given you some hints based on what I'm going to be talking with you about today, but there's lots of reasons why you could see a change in someone's heart rate, potentially a change in their orientation, agitation, and given the different things you're thinking about, what information would you need to gather, what would you look for to help you figure out that thing I'm thinking about makes more sense because I see the following things. I thought about this makes less sense because I gathered information and I found out none of these things actually fit. So say I'm thinking he's agitated and his heart rate's up because I think he's been using methamphetamines on the unit, right? Maybe that's what I think is going on. What would I need to know to help me rule that in or rule that out? So is everybody clear what the plan is and what you're going to do? So I just want you to take a few minutes talking with your neighbor about what do you think might be going on? What other information would you know? So I want you to keep calm, talk to your neighbor, and I'll leave this up just so it gives you some ideas to think about with this patient. So I'm going to stop now, and then when we return, Tim is going to be leading a discussion on what you all came up with for ideas on what could be going on and what information you would want to help you tease those things out. So let's take a break and you guys get busy. And now the TARDIS and the Rolodex, we have now come. So what kind of things, oh, no, so I'm sorry, I'm coming back now. So now we're back. So Tim has led a discussion, so you guys
Or one of the other facilitators.
Or one of the other facilitators has led a discussion, and you guys came up with a bunch of different ideas on what could be going on. So, and you talked about what you would need to, what information you would need to gather. So one of the challenges is lots of roads lead to a similar presentation of agitation. So all of you came up with a bunch of different ideas. This patient was agitated. You had all kinds of ideas on things that could cause agitation. So it's our job to sort out like what could potentially be driving what we're seeing with this patient. Sometimes it's what's going on in the unit with the environment. Have you all ever been on the unit when the milieu is intense and it revs up the patients? Ever? Sure, right? Like we see that all of the time. Maybe that's what's going on. Maybe they've gotten into it with another patient. Maybe it's instrumental. They actually are getting agitated because it helps them to get something that they want. Lots of medical condition can cause agitation. We talked about catatonia, not last year, but the year before. So you guys know there can be an agitated catatonia, thyroid issues, delirium, seizures, stroke, all kinds of things. Lots of psychiatric disorders can be associated with agitation. And then substance related, right? Both intoxication and withdrawal. So there's all kinds of roads that lead into agitation. So for this talk, we're gonna focus on a couple specifics, and you guys brought this up as possibilities of what we were seeing with the patient, with our Mr. Mystery Man, based on what the information that you had seen so far. So I like this table because it helps you think about, for delirium, dementia, and acute psychosis, what things can you use to systematically evaluate whether this is more consistent with a delirium picture, a dementia picture, or an acute psychosis picture. So for example, attention. For people with delirium, their attention is often impaired. That's a classic thing that you'll see with someone who has delirium. For demented patients, think about the demented patients you have on the unit right now, of which we have many, 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 because we can't get them out of the hospital. So for many of these patients early on, their attention is totally intact. You can have conversations with them. They may not always make sense, but you can have conversations with them. For a psychotic patient, sometimes their attention is impaired if their psychosis is so prominent that they're getting distracted. You all know how that happens. You're talking to the patient clearly. Something else is talking to the patient too, because they're not paying attention to what you're doing. But often, other times they can have clear attention to a conversation if their psychosis isn't so intense. A second thing to think about is onset or course. Waxing and waning or fluctuating course is a hallmark for delirium. It's one of the key things you think about when you think about a delirious person, and that it has an acute onset. So the person looked fine this morning, and all of a sudden, Jilly doesn't look so fine this afternoon. For patients with dementia, yes, they can have good days and bad days, but in general, it's a more progressive course. It isn't like they're completely cognitively intact, and then one day later, and for there on, they're completely demented. It's not usually how dementia presents itself. And for acute psychosis, because we're saying acute psychosis, it often comes on acutely. Sometimes for our patients, it can come on a little more gradually, depending on what type of psychosis and how it presents. Then there's perceptions. So illusions and visual hallucinations you see more commonly in patients with delirium. I had a great patient when I was a medicine intern, and this patient told me that she thought this was a nice hospital, but she did not understand why we allowed lizards in the hospital. And every night she would tell me that the little Geico lizard, he would just come walking around. He would do like a little samba, and then he would walk right out of her room, and she thought that that was really weird in this good hospital that we had that. That is not common for someone with psychosis. They tend to have a more systematized and consistent narrative for their psychosis. If you think about the patients that you're working with that have a primary psychotic illness now, it's very often very similar content day in and day out for those patients. It's very systematized versus this, which can be kind of a one-off and often more visual. And for perceptions for dementia, oftentimes is normal. Sometimes there can be a little paranoid ideation, but oftentimes they're not talking about visual hallucinations, they're not having auditory hallucinations. Alertness. So delirium can come in various flavors, which we'll talk about. They can be agitated, which is something like what they're describing in the case earlier, or they can be obtunded, so they can be completely kind of withdrawn. Whereas for a demented person, unless they're pretty far on, or unless they have frontotemporal dementia, sometimes you'll see a little bit more fatigue, they actually have a normal alertness. You'll see them on the unit sitting there. They may not know what's going on around them, but they're sitting there alert. And often for a psychotic patient, they're alert. They're not completely out of it. They're not obtunded. They could be potentially agitated, but there's something that can be obtunded. For cognition, this is also classic for someone with delirium, that they actually are not processing information and they're not oriented to what's going on. So you'll go in and they actually don't know that they're in a hospital. They may think that they're in a school, or they may think that they're in a shopping mall. They don't keep track of the date, but they actually knew the date the day before. So oftentimes there's an impairment. You can also see impairment with dementia. So you could, in demented patients, sometimes they're also not able to keep track of the date. For our psychotic patients, some of them they can, some of them they don't. It always surprises me. I'll be talking to a patient who's floridly psychotic, seems really disorganized, and then I'll just ask, do you have any idea what the date is? And they spit the date out faster than I can come up with the date. So sometimes they actually can have intact cognition, although I have had psychiatric patients who never keep track of the date, so it actually is impaired with them. And then finally, thinking. So you can see disorganization, challenges in processing information for people with dementia, with delirium. Oftentimes with our demented patients, there's impoverished thinking. So they tend to perseverate and think about the same thing over and over and over. And depending on the acuteness of the psychosis, sometimes you can see impoverished or disorganized thinking as well. So I think this framework is helpful because if you have someone, you're trying to sort out, is this an acute exacerbation of their psychosis? Is this someone who really, this is dementia with them? Is this someone who's delirious? You can think about these various things, and it helps you have a framework to think about where this person might be on this spectrum of things. So let's get back to our case. So I'm now telling you that not only does he have an elevated heart rate, he doesn't actually recognize the nurse that he did recognize yesterday. So he has the same nurse today, doesn't know who this nurse is when the nurse introduces himself to her. He's also not oriented sometimes, because you look at the doc's note and it identifies that they asked orientation questions and the patient was oriented. And now when the nurse is talking to them, the patient is no longer oriented. He's also worried that the nurse is trying to poison him. So when the nurse offers meds, he tells the nurse to go away because he thinks the nurse is trying to poison him. Has not had a problem with taking meds before, did not think that they were poisoned before. And in looking at his labs, he has an elevated white count and he's febrile. So with this information, what diagnosis do you think is more likely? I'm going to guess that you guys are thinking delirium, right? So waxing and waning course, is that this person is not thinking of processing, did yesterday, was oriented yesterday, not now, doesn't recognize the nurse, is now worried that the nurse is trying to poison him, but wasn't paranoid before, even though the patient has a diagnosis of schizophrenia, and now is febrile, has an elevated white count, and also has an elevated heart rate. So these are things that you would think with delirium. So as I mentioned earlier, delirium for the diagnostic criteria for the DSM-5, disturbance in attention and awareness, it develops over a short period of time, and it represents a change in function, and it fluctuates, right? So this gets to that waxing and waning course. And there's a disturbance in cognition, memory, disorientation, language, visuospatial ability, or perceptions, and it's not because they have dementia, for example, is what they're saying here. So, delirium, like ice cream, comes in many flavors, but there are three primary things we think about when we think about delirium. There's a hyperactive delirium, which is kind of what I was showing you was more consistent with what we were saying with our Mr. Mystery Man. So agitated or uncooperative can be combative, can be psychotic or responding to interval stimuli, loud, fast speech, wandering, restless, and can appear intoxicated. So these are kind of hallmarks of a hyperactive delirium. This person's going to get your attention, right? This is a patient who, if this patient is on your service, you're going to be paying attention to this patient because there's going to be agitated things happening. There's another type of delirium, which is the hypoactive delirium, where they're just kind of checked out. They're somnolent, disengaged, they're not processing, they can have variable behaviors, sometimes they seem somewhat with it and then they can slide into being kind of not so present, not saying a whole lot, which is often why they get missed because they're not complaining a whole lot. So these are the patients that can rot away in their room because they're easy. They aren't bothering you. They are not riding their call light. They're not the ones that are agitating. So these patients can kind of go under our radar for a while. Or you can have what I call the combo pizza, the combo action, which is a combination of both. So you can have hypoactive or mixed too. So the mixed is that you can have some things from hypoactive, some things from the hyperactive, and that's 80% of cases will be hypoactive or mixed. So that's going to be what you're going to see most often. So why am I talking about this? Because delirium is a big deal. First of all, it increases length of stay because these patients are sick, and sick they are. There's increased morbidity and mortality even up to a year afterwards, perhaps between 50 to 75%, as high as an MI and sepsis. These patients are sick. Delirium, I think of delirium as kind of like a surrogate for the level of illness that someone has. So if someone ends up with delirium, they're sicker than someone who doesn't necessarily end up with delirium, oftentimes because there's multiple risk factors, which we'll talk about. But this is a big deal. It's not just that, gee, they're a little bit loopy. It actually confers increased risk of other complications, including death, the death complication, but we're looking for the death complication. It can result in institutionalization, and I'll show you some data about that. Prolonged cognitive difficulties. People will talk about the fact that when their auntie or uncle or brother or sister or mother or father got delirious, they took a cognitive hit and they never got back after that. They never quite got back to where they were. So it can result in permanent cognitive deficits for some patients or cognitive difficulties. It is increased costs. They stay longer. The medical costs. If someone has delirium, we're going to do all kinds of workup. They're going to have all kinds of testing. They may have all kinds of interventions. That's going to be expensive. The emotional cost. If you talk to patients when they're no longer delirious, they will often remember being terrorized if they end up with some paranoia. They think, I had a patient who believed that they were actually being held in a concentration camp and that they were being tested on. What an awful thing for someone to have experienced. And what about the impact on the loved ones of this person, whatever, in our world, family means a lot of different things. So for the support people, for our patients, seeing them kind of out of it is really frightening. And so there's a cost with that as well. And once you've been delirious, you have an increased risk of delirium in the future. So we don't want to have delirium happen whenever we can because of all of these things. So common. The ones I want to talk about, sadly, for those of us, myself including, who are 55, I am now at risk for developing delirium. Crap. 60% of nursing home patients, that's what I was talking about when I was talking about institutionalization. Patients in the nursing home are there because they're sick, increased risk of delirium. It can then feed them having to stay in the nursing home and having to be more dependent. Lots of people in the elderly, 20% of all medical admissions, lots of hip fractures, elective surgeries, cardiac surgeries, up to 70% of the ICU patients. This is just an overwhelmingly common thing that we see. So, because it's so common, and because we have ways to detect it, the first thing you need to do is sort out how to detect it and what is the cause, because the cause drives treatment. If someone gets delirious because of a medication I'm prescribing them, it's a very different treatment than because they have a UTI and I need to give them a medication to treat their UTI, right? The treatment is going to be driven by the cause. And this is a key thing to think about. It's usually several things, and risk factors and exposures. It's a way of kind of thinking when you're assessing someone for delirium, what are these risk factors and what exposures have they had? So risk factors, age, sadly. Cognitive dysfunction, so people that have brains that are not completely tuned up, shall we say. So people that have depression, dementia, people with intellectual disabilities, visual impairment, so they're not having that sensory input, those can result in cognitive dysfunction, which increases risk. Having things happen to your brain, stroke, tumor, vasculitis, trauma, history of TBI, all of these are risk factors. Medical illnesses, like I talked about when I talked about the epidemiology of the frequency in which you'll see these occur in ICUs and significant medical things. So these are some risk factors. Exposures. People get sick. Electrolyte abnormalities, blood sugar abnormalities, UTIs, endocrine problems, CNS infections, nutritional deficiencies, intoxication and withdrawal, heat stroke, electrocution. I love those. Why did they specifically pick them out? I don't know, but that's what they did. I don't know. Sleep deprivation, do we ever see that in our patients? Medications, do we ever prescribe those? Yeah, so I'm gonna show you with medications. These are medications that are associated with delirium, anticholinergics and antihistaminics, analgesics, steroids, sympathomimetics, sedatives, anticonvulsants, antiarrhythmics, and antihypertensive, and antibiotics. Do any of you have anyone that you're providing care for that's on any of these medications? Probably the question is, do you have any of you have any patients that are actually on all of these medications at one time? Right, we do polypharmacy a lot. A lot of our patients are on medications that are deliriumgenic. So they may have risk factors, and then you're actually having these exposures that increase the risk of them developing delirium. So we thought about risk factors, we thought about things that could be contributing, that could be exposures. How do you assess it? So there's something called CAMS, the Confusional Assessment Method. I'm guessing most of you will have heard about this. We see it in the ICU is I think where it comes to mind oftentimes because the high epidemiology associated prevalence of delirium in the ICU. So the features of CAMS is one, acute onset or fluctuating course. The second is inattention. The third is disorganized thinking, and the fourth is altered level of consciousness. So these are the kind of four parts to the CAMS. And here's a graphic. I'm hoping it's not too fuzzy for you guys. So this is one that you can use in the ICU. So is there an acute change or fluctuation in course of mental status exam? The answer is yes, or the answer is no. And you're talking about in the past 24 hours, right? Because it can fluctuate, it can come and go. So it doesn't have to be the whole time that they're inattentive, but at times they're inattentive. If the answer is no, then they would say probably not delirium for that patient. If it's yes, then you can go on to inattention. With our patients, we may not squeeze hands, we may just have them tap on something, they can tap on their bedside or something, so you have a bunch of letters that you say, I love it, Casablanca, and I can't even say that, Abadabade or something. Anyway, so you have them either squeeze your hand whenever you say the letter A and you read the sequence of letters, or you can have them just tap. And if they don't make very many errors, 2 or less, not delirious. If they have 2 or more areas, then you look for altered levels of consciousness. If it's other than 0, then it's identified as positive. If they're not having any issues with altered levels of consciousness, but they're having disorganized thinking, will a stone float on water? Can you use a hammer to pound a nail? Hold up this many fingers and then they have to follow you. There's various things you can do. If they are not disorganized, you also say CAM negative. If they have 1 or more areas, then you also it'd be CAM positive, then you would identify that they have delirium. So there's assessment tools you can use to try to help pick up. And if you look at the literature, by using these as screening, they pick up way more cases of delirium that they had missed otherwise. So I think it behooves us to think about doing these things early. So let us get back to our most interesting mystery man. So let's get back to our guy. So I get medical records from an outside hospital. And what I find from the medical records is 3 months ago, he was found down and he'd been beaten up. He was found to have a TBI at that time. And he also had severe tib-fib fracture and he required surgery, which is why he actually still has a cast on his left lower extremity. And during his time in the hospital 3 months ago, he got delirious. So I want you to think about what we've talked about so far with risk factors and identify what risk factors does this gentleman have for delirium now. So your facilitator is going to pause me and you guys will talk about risk factors for delirium. And now we've come back and I will just reiterate that he had a TBI, he had surgery, which puts him at risk previously, and he got delirious before. So these are all risk factors, and he's also 50-some years old, so the age is also a risk factor for him. So he has multiple risk factors for delirium. So thing we do when we've got someone that's delirious is we try to sort out what the underlying cause is. Sometimes we use medication to treat it, but also sometimes the medications are actually what's causing it. We want to reduce psychoactive medications as much as we can. When we have a delirious patient who's agitated, benzodiazepines are not the thing that we use because that can cause delirium, right? We're gonna use something else like vitamin H, helpful. So, other things to do, supportive care for them. A goal is alert and manageable patient, not a sedated and lethargic patient. So what we don't want to do is create an obtunded patient. That's not what the goal is when we are trying to treat delirium. Sleep hygiene, huge for our patients. Low stimulus environment, much easier to say than to do, especially if we've got an intense milieu, as we like to call it, when we've got patients who are OOC on the unit. Having them have consistent staff, having people that know the person come in routinely can be helpful, and then trying to let the person rest, not doing Q15-minute blood pressure checks, and oh, let's get a lab, and now we're gonna get urine, and now we're gonna wake them up and send them down to chest x-ray, and all of those kind of things. So, that is delirium, and a little bit of dementia, and a little bit of psychosis in a nutshell. Since I'm not here in person, y'all can't ask any questions. Well, you can. You can check in with your facilitators and see if they can answer any questions that you have. But now we're gonna move on.
Well, I have a question.
Yes?
Dr. Combs.
Yes.
So can you have a little bit of delirium or either are you either delirious or not delirious?
Well,
what are the degrees?
Yeah, so Tim, who just asked a question, you can't see, but you probably recognize his voice, wants to know about, is it like, it's like being a little bit pregnant. You can be a little bit pregnant. It's like, no, you're actually pregnant or you're not. It depends on how far along you are. So delirium, someone can have just a touch of delirium. Like they actually are not fulminantly delirious, they're just having a touch of it. It's a little bit hard to detect that because you may not get a full pan clear picture if you do a CAMS, but you may think, ooh, this person has a lot of risk factors. Now we've been adding these exposures to them. They haven't been getting much sleep. They're on a bunch of medications that are deliriogenic. We need to get this person some rest, avoid anticholinergics. We need to start managing some of the risk factors and exposures for this person to try to catch the delirium as it's coming up early. It's like this, you think about a fulminant infection. You can get someone who has pyelonephritis because it had a UTI that's untreated and now it's ascended into their kidneys and now their kidneys are infected. Or you can have someone who has 1+ bacteria in their urine and a little nitrite positive and leukocyte esterase positive and a small amount of bacteria, right? If you catch it early, you're going to be able to treat it with very little intervention, whereas if someone has pyelo, they get to be in the hospital with IV antibiotics for a while. Delirium is the same, thinking about delirium in the same way, I think, can be helpful.
Thank you.
You're welcome. Thank you for that question. So now more audience participation. So some of you may remember this. Let's check your cognitive function from last year. This may look familiar. So what I'd like you to do is tell me which of these answers is correct. The death rate of drug overdoses in the United States has surpassed that of motor vehicle accidents. The rate of opiate analgesic poisoning death has quadrupled from 1999 to 2011, or the number of opioid analgesic overdoses involving benzodiazepines has increased 14% a year from 2006 to 2011. So which one do you guys think number 1 is correct, number 2 is correct, and number 3 is correct? So I'm sure y'all did a shout out in my absence, so now I'm going to reveal, and some of you may remember this, sneaky cheeks, all of these are correct, which is pretty impressive. These statistics are pretty amazing when you look at them in a non-amazing good way. Motor vehicle accidents have been going down, with the exception of this flattening here because of, you guys remember from last year, cell phones and people texting. Luckily has now started to go down again, but it surpassed in 2008 or 2009 the number of deaths from motor vehicle accidents. More and more people are having concurrent opiate death and benzodiazepine death. And these are additive, right? They result in respiratory depression, so it's very concerning that more and more benzos are being prescribed out there, as well as more and more opiates. And there's been waves in opiate overdose. First of all, there was a huge rise because of very effective drug company salesmanship, shall I say, on prescription opiates. So that was the first wave. The second wave was heroin became heroin chic again, so people started using more heroin again. And the third is there's a huge a rise in synthetic opiate overdose again. So you're seeing a big bump like fentanyl. All of you guys can think about cases in pop culture prints, for example, people dying from fentanyl overdoses. So, other sobering statistics. Over 630,000 people in this country died from a drug overdose. 66% of 663,000 drug overdoses in 2016 were involved in opiate. It was 5 times higher from OD deaths involving opiates in 2016 versus 1999. On an average, 115 Americans die every day from an opiate overdose, which is why we're talking about this and why you're seeing so much more about this in the press. So let's go back in our time machine and visit our Mr. Mystery Man. So this was the beginning of the case. 55-year-old gentleman with a previous diagnosis of schizophrenia admitted to the inpatient unit after having been down in the street with an abrasion on his forehead and a cast on his lower extremity, and his Utox was positive for codeine. So I want you to pretend he did not get delirious. All that other stuff we talked about didn't happen. So he is now, this is all we have about this patient. 2 days later, he becomes agitated, just like he did before, and his heart rate has gone from 75 to 115. And he's complaining about feeling some nausea, some stomach cramping, and he has a little bit of diarrhea, and then you notice he has goosebumps. So with this information, what do you think potentially could be going on for him? You are correct. He's going through opioid withdrawal. So it was a little disturbing to me. I searched Google Images and I said syringe bullseye, and they actually had a picture of syringe bullseye. I don't know what that means, but I found that disturbing. Anyway, so this guy is going through opiate withdrawal. So, time to play spin the urine. I wish I actually could have you spin some urine, it would be awesome, but that won't happen because there'd be pee everywhere and that would be a hot mess. So what I'd like you guys to think about is, this is our standard Utox list. Alcohol, amphetamines and methamphetamines, barbiturates, benzos, cocaine, methadone, opiates, PCP, cannabinoids, TCAs, and acetaminophen. So you think I'm giving you the answer to the next question, but I'm really not. I'm giving you hints, but I'm not actually giving the answer. So, given what I just told you, that this is what our standard Utox comes out as positive for, I'd like you to get into your pair share like you did with your other activity, and I want you to look at all of these different things: heroin, oxycodone, codeine, hydrocodone, and so on. And I want you to tell me which one of these would actually would show up if the person had been using it on our standard Utox. Not a long tox, but a standard Utox. So go ahead and take a minute or so to talk with your colleague. And so you can pause me now. Okay, now I'm unpaused. So, will heroin show up, yes or no? Yes. Will oxycodone show up? No. Will codeine show up? Well, Mystery Man's urine was positive for codeine, so probably the answer to that is yes. Yes. Hydrocodone? No. Fentanyl? No. Morphine? Yes. Diazepam? Valium? Yep. This one always kills me. Chlordiazepoxide, also known as Librium? Yep. Clonazepam? No. Alprazolam? Xanax? No. Synthetic cannabinoids? No. Lorazepam? Yes. The challenge with this is the classic thing. Someone comes in, has a history of opiate use disorder or opiate use. We get a Utox, they're negative. So we think, so they actually are telling us the truth. They say they hadn't been using recently. Well, see, we need to learn to trust our patients. And then 2 days later, the patient starts going through your opiate withdrawal. And you're like, well, what the heck? How does this person go through opiate withdrawal? Their Utox was negative. Oh, so guess what? A bunch of the stuff, but all the synthetic or semi-synthetic opiates don't show up. Do our patients ever take oxy? Yes, they do, right? So I think this, we get lulled into a sense that we know that the person isn't going to have any withdrawal issues when we get a negative U-tox. The reality is, unless we've gotten a long tox, they may actually be using and we just won't know that they're using. So, just as a reminder, opiate withdrawal timeline. This is last use, last dose. 6 to 12 hours if they're using short-acting like oxys, for example. Can be up to 30 hours if you're using long-acting like methadone. And the symptoms, it's a little bit easier to see here. These are the opiate abstinence syndrome, which you guys already picked up with our Mr. Mystery Man, right? Anxiety, irritability, restlessness, lacrimation, nausea, abdominal cramping, tachy, which our guy was, piloerection, she had, and again, it can last relatively long or short depending on the half-life of the opiate they're using. Yes?
What's piloerection?
Piloerection is goosebumps. Yes, goosebumps. Yes, thank you. Sorry about that. The nice thing is, people will not die from this in the hospital. People can die from alcohol withdrawal, right? People can go through DTs and die. There's mortality associated with that. People can have seizures from benzodiazepine withdrawal. So withdrawing folks from those substances are a little bit hairier because there's potential risk of significant negative outcomes, including death, which is a significant negative outcome. It's really kind of medically safe to have someone go through with opiate withdrawal. This is the problem. Oops, hang on. Hold my thought. It's one more slide away. So this is the things that we use to treat alcohol, or excuse me, opiate withdrawal when we're going to have someone just go through detox. We treat them symptomatically, right? We use clonidine to help if their heart rate's up, blood pressure is up. We treat their muscle cramps. We snow them to help them be more comfortable. We treat some of the abdominal discomfort. How many of you have actually had a patient that's gone through opiate withdrawal? Of course, all of you have. Do they look comfortable? Are they hunky-dory? Like when we treat them with all of these things, do we actually make them comfortable? No, we don't. It's actually a very uncomfortable withdrawal to go through. And this is the big problem. 90%, more than 90% of these folks, when they go through detox, when they leave our institution, will relapse. So they go through this uncomfortable experience, they have high relapse rate, and they have lost their tolerance. So then when they go back and use what they were normally using, then they die from overdose. So there's a risk associated with having someone just go through detox because we're reducing their tolerance, and we know the data shows that it's really hard for them to not go back to using. So it's kind of the elephant in the room about opiates. So what else can we do? What are other options to help our folks? Because that's clearly not such a great option. So we can either have them go through detox like we just talked about, not so great for many of our patients, or we can put them on some kind of maintenance treatment of some kind. So we can use methadone, we can use buprenorphine or Suboxone, which has some naloxone in it so people don't abuse it, or we can use something that completely blocks the impact of opiates. So I showed you guys this last year, I wanted to review it again. So opiate use disorder medications in the brain. So this is our little opiate receptor. Look, it's an empty opiate receptor waiting for something to come and fill it. So if you have the opiate receptor, methadone is what we call a full agonist, which means it has a full effect. Look at it. It nests right down in there. It completely gets into the receptor, and it fully activates the receptor. So we call that as a full agonist. So it's fully activating something. Buprenorphine is a partial agonist. So you see it sits down into the receptor, but it doesn't completely cover the whole receptor. It engages the receptor and also is blocking other things from getting on the receptor, but it doesn't completely activate it. So we call that as a partial agonist, so it has partial activity. Then there is an antagonist, which is a blocker. So it covers the cup, so nothing else can get inside it, and that's what naltrexone does. So if someone has a full antagonist, if they take something like methadone or buprenorphine, it can't get into the cup. So it blocks the impact, the effect. So if someone was on naltrexone and they took heroin, they wouldn't get a high from it because it wouldn't actually be able to get onto the receptor. So this is another way of looking at that. This is activity level of the opiate receptor. Antagonist, there's no activity, right? It completely blocks. Partial agonist, buprenorphine, has some activity, and then methadone has it's full agonist, so full activity. So it's helpful to think about that because it helps you think about when patients are on those different substances, what they would actually experience if they started to use opiates. So methadone has been around a long time, and it works. If you have a patient that's using heroin or using another opiate and you convert them to methadone, they're going to be taking an opiate, right? So it's going to it's going to sit in the receptor and activate the receptor. You actually have improved survival than people who are out using other kinds of forms of opiates because the dose is controlled. They're also not shooting, so they aren't having exposure to high-risk behaviors like sharing needles. Criminal activity, which I'm going to talk about, employment's better. They use less illicit opiates because they're actually able to deal with their opiate dependence and have their opiate dependence kept at bay rather than having to search around to try to find things, so they don't have to use as much illicit. It's a challenge, though, in some ways, in that they have to be in these programs. We never start anyone on the inpatient service on methadone because we're not a methadone program. We will continue what people have been on, but then, like, you know, the classic thing, they come in on a Friday night or Saturday, no one can verify their methadone dose. And then they have to start going without methadone for a while before we can get a hold of the methadone clinic. They have to have supervised dosing, counseling, urine testing. And how many of you have talked about how they score other drugs when they're at the methadone clinic in line? My patients say all the time, they say, if you ever need anything, you got two options. You can go to the bus stop right outside our emergency room at Harborview, or you can go to a methadone clinic, because people in the line are often struggling. So just because they're using the methadone, it doesn't mean that they're not going to be around others that are still struggling with their substance use. Having said that, though, it's cost effective. So the money that goes into methadone programs actually costs the system less. It's a very dark slide. What it shows you, if you could see it, is how much the mean days of crime. I love this study. And if you look at this is pre-treatment. 200 and some days a year these people are banging out crimes. Wow, that's impressive. Then you get them into treatment. This is 4 months, 1, 2, 3, 4, 5, 6 years out in methadone. So it really does help, because you guys know the old adage that really good people do really bad things in the context of their addiction. So when people are using and they're dependent on opiates, they'll do all kinds of crappy things in order to be able to feed their addiction. And when they're no longer having to do that and they're using a substance that's being prescribed by someone, they're really able to get away from a lot of that. The downside is you're still dependent on a substance. You have to travel to a clinic, sedation, constipation, poor concentration. You guys think about it. How do our methadone patients often look when you're interviewing them in the morning? Alert, perky, engaged, or more like, right? Often they're pretty snowed. So I think better than them shooting up, but it isn't necessarily that they're not experiencing the impacts of being on chronic opiates. So I think there's some downsides, even though there are some good sides to using methadone. This is also a huge concern. So they can use their methadone and then use other things on top of them, and they can result in respiratory depression and overdose. So you worry about the risk of overdose when people are using methadone, because remember the cups, the receptors I showed you, methadone sits on there, nothing else is sitting on there, so they could take other things that would have an additive effect to result in respiratory depression and death. So here in comes super Suboxone. You guys remember this, probably this slide from last year. So Suboxone is buprenorphine plus naloxone. They add naloxone in there because it will block you getting in high if you use a concurrent opiate. if they use it IV, it can cause problems, and some patients melt their dissolvable tabs or dissolvable films and use IV, but still, it can help reduce opiate use, and it increases abstinence of other substances. It compares to methadone as far as reducing opiate use. It's not quite as high of retention and treatment compared to methadone, but it's much, 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 much safer. It is really hard for a patient to overdose on this medication, so it's way safer than what we've got with methadone. So it helps with alleviating withdrawal. So how many of you have had the experience of actually starting a patient on Suboxone in the hospital? I'm hoping some of you have. So I've seen it when we start Suboxone on a patient, they can feel better like almost immediately. They don't have that awful detox, the feeling that they go when they go through detox. So it can be really helpful for patients. It also can result in potentially less length of stay because you can get them going really quickly. Challenges are that the provider needs to be a certified prescriber. All of us have now gone through Suboxone training since our last psych skills that we had last year, so that shouldn't be a barrier anymore. You need to have an outpatient provider, just like with methadone, because you don't want to start something on for someone and then not be able to have them get it as an outpatient unless you're just using it to go through detox. But most of the time we're thinking about longer term, otherwise the same issues are going to happen when they leave the hospital. And you still want them to engage in outpatient CV programming, just because you all know substance use disorders is not going to be fixed by a pill. It's going to be fixed by a whole psychosocial support that's no different for Suboxone. So first thing to do is think about, is the person a good candidate? Are they actually dependent on opiates, and do they want to stop using opiates? Number two, are they willing to engage in outpatient treatment and take medications? And then we have this fantastic addiction service, and often we'll have them come in, help us out, because they do really great MI with patients, and they also help us connect them to outpatient services, because we got to get the other part of their treatment. There's an inpatient part and an outpatient part. So what we do is induction, which is what we do in the hospital, and stabilization, and then maintenance, which is occurring in outside the hospital. So you don't want to start buprenorphine too soon. You want them to have started actually going into opiate withdrawal. Otherwise, when you give it, you're going to precipitate a bad opiate withdrawal, which will not be very pleasant for the patient. So you want to do cows, and all of you, I'll make sure that you have the cows. This is the clinical opiate withdrawal scale. This is very familiar, I'm sure, to many of you. So you want to have a cows of 8 or greater, and that depends on if they're using methadone, going to be a while. If it's something like oxycodone, it will happen within 8 to 16 hours after stopping their use. Start at 4 milligrams twice a day. You don't exceed more than 12 milligrams in the first 24 hours. And then you up titrate as needed depending on the symptoms of the patient. Some patients get relief at 8. Some patients need 16. So the only way we'll know is by starting it and then checking in with the patient and seeing what they're experiencing. And if they're still having cravings, having withdrawal symptoms, then we need to move up. There is now a power plan for buprenorphine, which all of you should be familiar with, or excuse me, the Suboxone program. So all of you should be able to look at that on the power plan. It has very specific things. The last thing I want to mention is we also have naltrexone as an option for opiate dependence. Naltrexone, like I talked about, is the thing that completely blocks. So the cup is completely blocked, the receptor is completely blocked. It's a full antagonist. So that is an option for some patients if they do not want to do replacement therapy. They want to stop using opiates. It comes in an oral form. The dropout rate is relatively high. So what we like to do is give them an injectable. So there's something called Vivitrol, which is a depot form of the naltrexone they can get once a month. The data is coming out more that this is pretty successful for a subset of motivated patients. And so this is considered a first-line treatment, which methadone and buprenorphine are also considered. So you may or may not see a little bit more of this. Naltrexone is also used for people with alcohol dependence. So often if you have someone with concurrent alcohol use, this might be a good option for them. So this is another option I just wanted you guys to be aware of. So, the best treatment, however, is to prevent these patients from getting addicted. So think about opiates like steroids, aggressive doses, short bursts, quick tapers, rather than this chronic thing. The US population constitutes 4.5% of the whole world's population, and we consume more than 30% of the opiates. A great example of this is my husband blew his knee out. You don't even want to know how. Ninja Warrior thing in Salt Lake City. Went to the ER there. They gave him like 12 tabs of something, some opiates, till we could get back home and see a surgeon and all that, which I thought was a reasonable thing. Had his surgery. The surgeon wrote him for 60 oxycodone. 60 oxycodone. And I'm like, I went to pick him up, like, he doesn't need this many oxycodone. If you look at the data, people that abuse prescription meds most often get it from someone else's medicine closet, right? So it's part of the job as us working in healthcare to be good stewards for prescribing. And what we need to do is be much more cognizant of how much we actually are prescribing of opiates, because this is not helpful. This is one great study that showed people that had back injuries, if they stayed on prescription opiates for more than 7 days for an acute back injury, there was a significant risk for them becoming on long-term disability. And they corrected for pain, function, illness severity, and other covariates. So the only significant thing that showed up was if they were prescribed opiates for longer than a 7-day period. I think, again, just shows that we need to be cognizant of these medications are not benign and they are not good for treating chronic pain, so we need to do something different than what we're doing now. So with that, we're going to return to our mystery man for the final time, and we talked to him about his opiate use, and he identifies that he's dependent, and he decides that he wants to start Suboxone. So one bad chapter does not mean the end of the story. So this is a new chapter for our Mr. Mystery Man. So since I'm not here, the moderator who is running this will hopefully be able to answer any questions that you have, or if there's questions that come up, they can always get them to me and I can get them sent to you by email. So that's it. Thanks, guys.